Later, we have Dr. Annu JOON, who will be talking on, now we come to the therapeutic aspects of combined lens and glaucoma surgery in advanced angle closure glaucoma.
Thank you, ma'am. So I think my job has been made really easy with the talk that Dr. Kirti Singh has already given about the role of lens and the parameters such as lens vault and iris curve and iris thickness in angle closure glaucoma, and made further easy by the talk that Dr. Siddharth Dikshit has already talked about, the role of MIGS and combining it with phacoemulsification in all the studies and videos that he's already shown you. But let me summarize it once again for all of you. So the role of combined surgery, we need to assess what are the treatment challenges when we take up a patient of advanced PACG or any angle closure glaucoma, the indications of such a combined surgery, the techniques that we have to adopt, what are the benefits that this combined approach gives to us, and the challenges and the risks associated with it, and the latest, that is the phaco-MIGS in angle closure glaucoma. The disease burden of PACG, like Dr. Kirti Singh highlighted, as for the world account, PACG accounts for almost half of all the glaucoma blindness worldwide, and Asians account for more than 3/4 of the PACG population. So it's quite rampant in our Southeast Asian community. And talking about the Indian scenario, we have 11.2 million persons aged 40 years and older in India with glaucoma, of which PACG affects 2.54 million. Now, the treatment challenges are multifactorial in nature. If we talk about an older age, most of these patients are complicated with a coexisting cataract, higher IOPs, and an advanced optic nerve damage. In younger age group, we face challenges with a clear lens, that is the high lens vault that we've already talked about, and shallow anterior chambers, which may predispose to post-trabeculectomy sequelae and a long dreaded post-operative period. When we talk about the limitations of the traditional treatment approaches, if we take up cataract surgery alone in these patients, they may not lower the IOP sufficiently, especially when we tailor the approach in cases of advanced ACGs and the kind of patient profile that comes to us, who have advanced damage with very high IOPs, sometimes in 40s and 50s. Glaucoma surgery alone may control the intraocular pressures, but the sequelae, we always talk about the post-trabeculectomy sequelae and a long post-op period that we have to follow up the patient for when we compare it with phacoemulsification. And these sequelae with shallow anterior chambers in a pre-existing shallow AC can be dreadful. Also, these patients already have a very tunneled vision with advanced damages and macular splits on visual fields. And that some amount of cataract progression may also affect their functionality significantly. So a combined approach gives a more holistic solution to these patients. This is a picture of a patient who underwent a trabeculectomy in a ACG patient. He had some amount of cataract, didn't appear to be significant to us initially, but as you see, the chamber is very, very shallow. In the center picture, you also see that the peripheral iridocorneal touch, it's just sparing the peripheral angles. It's already VH grade 1. And on down gaze, it appears as if there is a touch, although there wasn't. So cataract progression can occur really rapidly in these eyes if we do not adopt a combined approach. A lot of journals have focused on the impact of early lens extraction in the treatment of ACG, like the EAGLE study. But the disadvantage here is that they've compared it with standard care of laser peripheral iridotomy and topical medical treatment. That may have an effect in cases of early to moderate ACGs, but when we talk about advanced ACGs, just a laser PI and topical treatment may not be able to achieve the target IOP. The studies who focused on with combined phacotrabeculectomy are mostly associated with medically controlled angle closures. So if a patient is controlled on medications, we can still tailor our approach more or less around phacoemulsification. But when we talk about uncontrolled glaucomas, trabeculectomy has to be done. Studies also have compared phacoemulsification versus trab in medically uncontrolled, and they found out that trabeculectomy treated eyes required on an average fewer drugs than only phacoemulsification eyes. Why do we fear this trabeculectomy so much? Trabeculectomy, as they concluded, is definitely more effective than phacoemulsification, but is associated with more complications. But a well-done surgery and a well-followed-up patient can help us prevent these complications or manage them better, but our primary aim has to attain the target IOP. The kind of tailored approach that we have to focus on the patients. Our patients are mostly who have very advanced glaucomas, a 0.9 cup. They present to us already in the stage of relative afferent pupillary defects, tunnel visions, macular splits. There are issues with medical compliance because they don't understand what they're gaining. They say, when did I take my medication last? They don't remember. They have forgetfulness issues. There are cost issues associated with the same. And of course, they're not seeing any improvement in that already damaged visual fields or the functionality. So they feel it doesn't really matter until they worsen further. Hence, the importance of combined surgeries. Our goal has to be primarily to reduce the intraocular pressure, but also preserving the vision or improving where we can by removing that even smaller or insignificant amount of cataracts. You have to minimize the need for multiple surgeries because these patients may not come back to you unless the cataract has progressed much harder, and then there are risks of trabeculectomy failures in those patients when we operate them again. Dr. Kirti ma'am has already talked about the role of lens vault in these patients, and further shallowing may happen if you do just a trabeculectomy. So in cases of cataracts, you definitely need to remove them, but in clear lenses with high lens vault or lens thicknesses, again the role of lens handling becomes important along with trabeculectomy. Field medical management is again an important indication, and higher IOPs along with some amount of cataract progressions. Talking about the surgical techniques, we can go in for a single site approach wherein you do a phacoemulsification along with trabeculectomy at the same site. However, we generally prefer a two-site approach wherein you open up you make a flap superiorly, do a phacoemulsification from the temporal incision, and then go back and complete your trabeculectomy in the superior site. This has shown to have higher post-operative success compared to same-site trabeculectomies. The benefits are that there is improved intraocular pressure control, enhanced visual outcomes. That slight gain of vision or slight improvement in contrast goes a long way for these patients physiologically and functionally. Challenges, however, again, are the increased surgical complexity. Even doing a plain phacoemulsification in these eyes is not easy. You encounter high convexity of the lenses, difficulty in the rexes, and iris prolapses in these patients. However, the future now is also phaco combined with MIGS, like Dr. Siddharth has already talked about. But what are the challenges that we face in this? The most important challenge is the direct gonioscopy, which is a diagnostic tool. So I would encourage all of the audience sitting here, even when you're doing a cataract surgery in an open angle or a normal phaco patient, make your patient lie down on the table, tilt their heads, turn the microscopes, at least try to visualize how an angle looks on direct gonioscopy. Maybe go in with your blunt cannulas, try to touch those structures at the angle, so that when you encounter an open angle or an angle closure glaucoma patient, you have the caliber to operate on these procedures and do a successful MIGS. So learning a direct gonioscopy is really important and goes a long way in performing these surgeries. The indications, however, I would say should be medically controlled ACGs. Uncontrolled and advanced ACGs should be reserved for trabeculectomy. Surgical challenges again are the shallow ACs, which will hamper our management, but they may be performed after lens removal. So once you've done a cataract surgery, the angles open up and gives you enough space to perform a MIGS. Studies have compared long-term outcomes of combined phaco with KDB in different subtypes of glaucoma, and they found out that in ACG eyes, mean baseline IOP had decreased by 23% and the number of medications by 56 to 87%. And this is how an angle after a KDB looks like sometimes. Even in ACGs, the angles open up really nicely. There have been no documented studies of bent angle goniotomies along with phacoemulsification in ACG as far as I could do my literature search. But we are already doing a study under Dr. Kirti Singh in Guru Nanak Eye Center, and we've had promising results so far. And this is how nicely the angles sometimes open up after bang even in ACGs. Studies have also been done on chronic ACGs with phacoemulsification and ECP. And they've also found out that the IOP reduction was 26.2% in the ECP group. And the ECP group, which did not undergo goniosynculitis, had less pars formation. This is one of the surgeries highlighting ECP, and the advantage it gives is that you can bypass that angle and you go behind. So once you've done your lens surgery, you visualize the ciliary processes and you can coagulate them. This is a 360, almost a 270-degree view of how these coagulated ciliary processes look like. GAT has also been combined, and Dr. Siddharth has shown a beautiful video of GAT being done in ACGs. So I would like to conclude by saying that the approach has to be extremely tailored. If you have advanced glaucomas but medically uncontrolled pressures, go in for combined phacotrabeculectomies or tubes. However, if you have controlled glaucomas, like in the range of maybe late teens or early 20s, on anti-glaucoma medications with compliance issues or side effects, phaco mix can be a way for you. Thank you so much.